and welcome to today's presentation, Radiation Therapy, Understand Your Options. I'm Steve Reinches, President and CEO of North Kansas City Hospital. Thank you for joining us. Radiation therapy is commonly used to treat cancer of all types. Through our partnership with the University of Kansas Cancer Center, people with cancer have access to radiation therapy and other advanced treatments right on our campus. I'm excited to have Ajay Tejwani, MD, here to talk about the different types of radiation therapy and how they fight cancer. Dr. Tejwani is a radiation oncologist with the University of Kansas Cancer Center. He works exclusively on North Kansas City Hospital's campus with our radiation oncology team. Dr. Tejwani earned his medical degree from Tulane University. He completed his residency at the New York Presbyterian Hospital, Weill Cornell Medical Center. He is passionate about providing access to the state-of-the-art cancer care and clinical trials to our community. Please join me in welcoming Dr. Tejwani.
Wonderful. Thank you, Dr. Righteous. As Dr. Righteous said, I'll be talking to you a little bit today about radiation oncology and the various treatment modalities. And really, this lecture is going to be serving as an introduction to all of you as a understanding of radiation oncology and how it works. So on today's lecture, I have several objectives. I want to define the field of radiation oncology for those that are unfamiliar with it. I'd also like to go a little bit into how radiation therapy works and how it actually impacts tumor cells, excuse me. I also want to identify and distinguish different types of radiation treatments and the delivery systems. Of course, I also want to outline a little bit about what's offered to our patients here in the Northland. I'm going to spend a little time reviewing common disease sites where radiation aids in management of tumors. I also want our patients to understand how a patient pathway works in the radiation oncology department. Maybe you have a family member that's going through radiation, or maybe you're going through radiation yourself. And then lastly, I want to spend a little bit of time outlining the side effects of radiation therapy and how they are split up. So radiation oncology as a medical field is the discipline which uses ionizing radiation in the treatment of cancer. This radiation is damaging, and of course that's what we want to treat the tumor cells. Now, many people are already familiar with radiation in the form of diagnostic radiation or radiology, where radiation is used to take an X-ray, for example, or a CT scan. The field of radiation oncology switches over to therapeutic, where radiation is actually used to treat. I often tell patients that radiation is part of the cancer fighting toolbox. In addition to surgery and chemotherapy, it's one of the big three, is what I tell patients. And it has been around for more than 100 years and has been a very effective cancer treatment and is evolving every year. Current estimates are that about 2/3 of all cancer patients receive radiation therapy at some point in their care. So I myself am a radiation oncologist. I practice here primarily at North Kansas City Hospital. I'm affiliated with KU. And I became a radiation oncologist through a 5-year residency. Historically, before radiation and oncology had become so sophisticated, radiation oncologists actually trained out of radiology. As a radiation oncology, I oversee all of the radiation therapy treatment, and I work closely with medical oncologists and also our surgeons, of course. Now, in terms of cancer care, radiation has multiple roles. I split this up into definitive or curative roles, and of course, palliative. In terms of the definitive role of radiation, it can often be used by itself to treat cancer in combination with chemotherapy, which is concurrent chemoradiation. And also it can be used before or after surgery. Adjuvant means after surgery, and neoadjuvant means prior to surgery. Also, radiation has a big role in palliation and improving quality of life for patients that may have metastatic disease and have symptoms such as pain, bleeding, or neurological symptoms, etc. Radiation has demonstrated increased presence in national standard of care oncology guidelines, and you have some of the organizations there on the right. Now, there has been documented or written about standards of radiation used in multiple disease sites. Commonly used areas include prostate, breast, lung, and so each disease site has a different form of radiation that can be used, different fractionation scheme, different length, and I'm going to review some of those later today. Now, oftentimes patients ask me how radiation works. Radiation represents an electromagnetic light. It's similar to radio waves, radar, radiant heat, and visible light. These are all forms of electromagnetic radiation. The difference is that they have different wavelengths and frequencies. And by adjusting that, you can actually impact cancer cells. When you talk about radiation dose, it's often described as the unit known as gray, which is just joules per kilogram. Other forms that you may see are rads, sieverts, or rems, but these have kind of fallen out of favor for the predominant what's called gray. Now, in every radiation department in the country, typically houses a machine called a linear accelerator. This is how patients are treated with radiation therapy. A linear accelerator is the machine that generates the X-ray. The way it does this is it actually is able to accelerate, hence the name, the linear accelerator, something called an electron, if you remember from your science class, towards a metal filament. By the collision of that electron with the metal filament, a X-ray is then generated. That X-ray is then directed towards the patient from this head. Now, that head has attachments which allow the beam to be modified, which I'll go over. Various attachments and computer software can be used to kind of generate a radiation plan or beam to modify that beam to target a certain area. Additionally, radiation itself can be introduced in the body permanently or temporarily to also locally direct X-rays towards the patient. Historically, prior to the advent of linear accelerators, oftentimes machines would hold a radiation source right here, and a lead chute would open up that would allow radiation to be given to the patient directly. Now, how does radiation work a little bit more deeper? How does it kill tumor cells? The main impact that radiation has on tumor cells, and the reason those tumor cells then subsequently die, is double-strand breaks in the tumor's DNA. Now, a cancer cell, when I talk to patients, is a cell that no longer respects the normal soft tissue DNA where it normally goes through a life cycle. A tumor's DNA often tells it to just keep replicating, hence cancer cells can keep growing and metastasize, etc. The radiation itself causes double-strand breaks in a tumor's DNA, which then results in the tumor cells dying. Damage from radiation can be done both directly or indirectly. Directly would be a direct hit from the radiation to the DNA. Indirect would be impacts from the radiation causing the generation of something called free radicals, which then result in damage in the DNA. Now, going back to our science classes from grade school, tumor cells often move through various cell cycles as they kind of generate and reproduce. So radiation treatment is often broken up into fractions to capitalize on this, meaning that as cells kind of go through their cell cycle, they're hit with radiation at different times. Radiation doesn't always kill cancer cells or normal cells right away. A tissue's growth rate often dictates the timing of the radiation damage. So for example, our skin, our intestine are often regenerating all the time, hence radiation can impact them more. Side effects may not be seen until long after treatment is over. And so that's something that we'll talk about in the side effects. So now turning our attention a little bit to the pathway of a patient in the radiation oncology department. This is a broad overview. A radiation patient is initially seen for consultation. If the patient is decided that they will benefit from radiation, we will put them through the process of simulating the patient, which I'll go over, and then generating a radiation plan. They will start their treatment with me, and then weekly we will see them. Eventually they'll finish treatment, and then they'll become a follow-up patient that will follow. So exploring that a little bit further, in every radiation oncology department, there is a radiation oncologist, who is myself, a physician, and there's a radiation physicist who helps maintain the department's radiation treatment machine, does the quality assurance, and ensures the safety of the radiation facility. A dosimetrist is a team member who generates a radiation plan, and then the actual treatment itself is carried out by the radiation therapist in the department. And of course, to manage the intake of patients, the side effects of treatment, a nurse is always present in a radiation oncology department. So a patient is seen in consultation first. This is the initial visit with the radiation oncologist. During that time, we take a history and comprehensive physical. Of course, we pay special attention if the patient has gotten radiation treatment in the past. We go over there if they have any childbearing potential. We review all their radiology. We talk with the referring providers, and then we make a determination at that time if radiation treatment is appropriate. If we ultimately elect to give radiation to the patient, then they will move on to the radiation treatment planning process. Now, this process is started by an appointment called a simulation. Each radiation oncology department has a CT scanner in the department. And during that time, we actually scan the patient in what's known as the treatment position. We use a variety of different devices to immobilize a patient with the intention to be able to reproduce this position every day. So here you see a patient in something called a vac lock, which I describe to patients as a mattress that can be fixed to the patient. Here you have a patient wearing a face mask. They will wear this face mask each day for treatment, so we know exactly where all of their anatomy is in relation to the treatment machine. Here's several other examples of commonly used patient positions where patients would get treated. Now, at that point, the patient leaves the department, and there is a time period of about a week or so where we actually plan the radiation. As radiation has become more modern, everything has kind of moved towards more computer-based planning. The radiation software can model how radiation will impact the patient's tissue, and we can adjust beams with various forms of blocking to avoid at-risk organs and make sure the area of target, in this case the tumor, gets the prescribed dose. The computer itself calculates the radiation beam and optimizes the angles and everything alongside the dosimetrist. And then at that point, we're able to evaluate a plan to see, one, if the target is treated appropriately, but then if the at-risk organs are safely under our radiation thresholds. This would be an example of a radiation plan that would generate. Here you have patients' radiation dose isodose curves, where in this patient is getting treatment to the larynx. So this red represents the area of highest treatment. They're getting this 70 gray, going back to that unit that I mentioned. During this process, the additional organs at risk, such as the esophagus, here you have the spinal cord, are all evaluated to ensure that they don't get an unsafe radiation dose. Below, you see something that we as radiation oncologists use to evaluate the dose to all these organs. Now, once that radiation plan passes all the quality metrics and is approved for treatment, the patient then returns to start the actual treatment. During that time, the setup is done again, of course, because that's the treatment position, and all treatment fields are confirmed. Once we ensure the patient can be adequately set up in the exact same position, we deliver the treatment. Now, the radiation treatment itself is often about 1 or 2 minutes. But from the time of setup to the time of getting the patient off and ensuring everyone's in the right position, et cetera, it takes about 10 to 15 minutes in the department. The treatment course typically lasts anywhere from 3 to 9 weeks, with a increasing presence of using a utility of these shorter courses of treatment, which I'll review. During that time, a physician is always present, but I meet with the patient once a week to ensure the side effects, et cetera, are managed appropriately. Now, as I mentioned before, we often fractionate. Many patients will often ask me, why can't we just do this in one treatment? And it goes back to that cell cycle graphic that I mentioned, that oftentimes tumors are cycling through in different stages of their reproductive cell cycle. And so you have to make sure you hit them at the right time so their DNA will be damaged. Despite all the advances in delivery, all radiation plans, both the target and normal tissue are irradiated. And so we have to also fractionate to be safe for the normal tissues. Oops, sorry. Now, after the patient finishes treatment, they then become a follow-up patient. During that time, at regular intervals, every 3 months, they will be seen to ensure that they've recovered from the acute effects of radiation. Additionally, we'll of course make sure that what the status of the disease is. Has it returned? Is there any other new sites? We'll also start looking at if the patient has had any long-term side effects of radiation. During that time, imaging and laboratory data will also be reviewed. And then after 1 to 2 years of this follow-up, the follow-ups typically transition to only a single provider, so there's not multiple providers following the patient. Now, turning our attention to radiation treatment itself, much of my conversation has kind of focused on external beam radiation therapy, which is the most commonly used type. There's also 2 others, brachytherapy and systemic radiation treatment, that are often used as well. External beam radiation refers to where a machine directs radiation beams towards a patient. Brachytherapy is the actual placement of radioactive sources in or near the tumor, which I'll review. And then lastly, systemic refers to radiopharmaceuticals, where a patient is injected with a radiation source or solution to kind of deliver it systemically, and then the body excretes that radiation. So external beam radiation comes in several forms. Photon therapy is the most common across the country. There's also particle therapy, which I'll review. Within photon therapy, there is kind of 4 major types that I wanted to review to give an overview, which I'll review in the coming slides here. So historically, when radiation therapy was first used for patients, it was used even prior to the use of CT scanners. A patient would have an X-ray, and if that 2D X-ray would be used to generate a radiation field or a block. So you see here a patient is getting treatment for the stomach, and these lines right here are the physician where they wanted to block. So they want to treat the area that's open. This often resulted in very large fields, and of course, giving such large fields resulted in increased toxicity, et cetera, than we see now as we use more CT-based planning. As CT imaging became more common, this was probably around the late 80s, this allowed us to better visualize organs in a 3D visualization. It also allowed us to better see the target and avoid organs at risk. So with the advent of CTs, this led to 3D conformal radiation, which is how we majority base our patients' plans based on CT scans. So everything's done by a CT scan in our department. A radiation oncologist will contour on each slice, so basically draw the target and organs at risk. By doing this, you're then now able to get a better visualization of where organs are. In this case, this patient had his kidneys are here, the patient's liver is here, and then you can see this magenta represents the target. Of course, this better also allows patients to be better planned. You can get a better idea of making tighter blocks and conforming the beams in a more conformal way. This also allowed multiple beam arrangements around the target to better blend the dose. So as the beams come from multiple angles, you get a better distribution of dose, radiation dose. As computers got more sophisticated, we got a better understanding of radiation. 3D conformal then led into what's called intensity modulated radiation therapy. Now, if you remember, I talked about the linear accelerator and the treatment head. Within that head are multiple lead leaves. These are called MLCs, multi-leaf collimators. Those leaves can be introduced within the beam to really distribute the dose in a conformal way. So you can see here, as this head and neck patient is being treated, these lead leaves are moving, giving radiation a varying distribution. This even better allowed us to limit radiation dose to organs at risk. So here at the bottom figure, this would represent a 3D plan. You can see a big box where the target's getting the full radiation dose, but also the organs at risk here in the center, which represents the bowel, etc. With the advent of IMRT, that dose can be better sculpted to kind of only go towards the target. Just as computers got more sophisticated, the treatment machines themselves, the linear accelerator, you have an image here that shows an example of a linear accelerator. We were able to add visualization tools onto the machine to give us a real-time imaging of the patient and the treatment target itself. So this led to image-guided radiation therapy. So for example, within our own department here at North Kansas City Hospital, if a patient, say, is getting treatment to the prostate, we can do a small CT scan called a cone beam at the time of each treatment to ensure that not only is the prostate in the right position, but also is the bladder adequately full, has the patient had a bowel movement, and other things, just to make sure all of the volumes are in the right spot. This allows us to reduce the account for areas of uncertainty better. So here you have a patient that was being treated for prostate cancer, as I said, and we actually place markers within the prostate. Those can be followed to ensure that they're in the right position and even be tracked in real time. Lastly, with regards to external beam radiation, a more frequently commonly used form of treatment is stereotactic radiotherapy or stereotactic body radiotherapy. This refers to treatment that is given in a limited number of fractions, often less than 5. It's very high dose to a small area. This limits the amount of trips. If you remember, I said patients often get 3 to 9 weeks of treatment. This is done in less than 2 weeks. The immobilization and imaging of these patients is much more precise. Often it requires MRI planning and fixed devices, which I'll show you in a second. A variety of machines can be used to offer this focused type of treatment. Linear accelerators, which I said are commonly used in the majority of radiation departments in the country. Gamma knife, which involves a special helmet which a patient wears and is placed in a machine where there's cobalt sources all around the patient. And then lastly, cyber knife, which is a independent gantry that can move around in various directions. Ultimately, the treatment outcome is the same, in a sense that the goal of stereotactic radiation therapy is to give a high dose in a limited number of fractions. So of course, the advantages of stereotactic radiotherapy is a shorter treatment course. The control weights are very high given such a high dose of radiation. And because it's such a small area, the side effects are often limited. The disadvantages is not all patients can receive this type of treatment. Oftentimes it has to be a very small volume. The treatment time can be long, up to 30 to 60 minutes. The immobilization can be very uncomfortable. And if side effects do occur, although very, very rare, they can often be somewhat severe. So this would be an example of a stage 1 lung cancer that received stereotactic radiotherapy. You can see how conformal, there's hardly any dose going around elsewhere to the patient. This would be an example of a brain tumor that got stereotactic radiation. And you can see, as I was describing, the immobilization is very rigid. This patient cannot move, so we can focus on the order of millimeters, this volume right here, to give a high dose. Oftentimes, stereotactic radiation in this location is given in 1 fraction, which is referred to as radiosurgery. Now, moving on, particle radiation therapy is the description of particles directed to give radiation damage. Now, the majority of what I've discussed has been photon therapy, but particles such as electrons, protons, neutrons can all be directed towards the patient to give radiation dose. The advantage here is that the distribution of the radiation dose is much different. Electron therapy is probably the most common particle therapy used. Photons, which is just light, the X-rays that I described, pass through the patient. These penetrate deeply and reach internal organs, and oftentimes that's the goal. Electrons are much heavier than photons, and therefore their distribution is superficial. So this is the top graphic here is photons, which are going very deeply. Here you see an electron, which by 2.5 centimeters has distributed all of its dose. We typically use electron therapy for skin because, of course, if a patient has a skin cancer, we don't want the X-rays to go deeper than the superficial skin cancer. Photons and electrons can be carefully mixed. Often linear accelerators, as I described, can treat electrons, and then of course they can treat photons is their primary goal. Now, proton therapy has, in the past 10 to 15 years, really increased in adoption across the country. Proton therapy has 2,000 times the mass of electrons. Protons penetrate tissue at a variable depth, and they deposit that energy in a very sharp peak. So I'll explain. Here on this green graphic, you have normal X-rays. This is the depth from the body surface, and you can see the X-ray continues to deliver dose all along and kind of passes through the patient. Here, this magenta is the tumor depth, where the tumor is. Now, using a proton beam, which is here in the red, the proton impacts the tissue, and immediately as it hits the density of the tissue, it slows down, right? And delivers the dose here, and as it slows down, it's delivering dose. As we reach a certain depth, it stops, right? And this is the advantage of proton therapy, that you can direct where the exit is and where it's going to stop. By using different energies of protons, you can make very, very conformal plans, even more so than the photon plans that I've been showing you. This can decrease radiation to adjoining normal tissues by a factor of 2 to 3. So proton therapy has very specialized uses. Of course, pediatrics, where you want to limit the amount of extra organs that are getting radiation, especially in a young patient. The eye, where there's many eloquent structures, nerves, CNS, where you want to avoid the spinal cord. It is also being commonly used in prostate, but with the modernization of computer software and the IMRT plans that I mentioned, the outcomes are often very, very similar. Now, moving on from proton therapy and external beam radiation therapy, we will talk a little bit about brachytherapy. Now, external beam radiation was historically known as teletherapy, or therapy given from afar. Brachy is Greek for short, and what brachytherapy represents are where radioactive sources are placed directly within or in very close proximity to tumors. The advantage of doing this is that as you move away from a radiation source, the dose falls off inverse proportionally to the square of the distance. So there's an exponential fall off. And so many times when we reach a limit from the amount a photon plan can give, additional radiation can be given by actually placing a radiation source into the patient or near a patient. For example, the prostate or a gynecologic malignancy. This allows us to dose escalate or give a very high dose to the tumor while reducing the dose to the surrounding structures. Now, the way we deliver brachytherapy can be with radiation sources themselves, or we can actually introduce an applicator in a fixed position, and then a separate machine called the afterloader introduces a radiation source in a filament, puts it into the applicator, and then removes it. So this would be an example of a gynecologic applicator. Here you have a patient with a cylinder. This white here represents a cylinder, and this has a cavity within it. And a small catheter can go in here, and within the radiation department, we can have a radiation source go in to the cylinder to deliver radiation to this area. Okay, and this would what it would look like. So you can see hardly any radiation goes anywhere else other than this blue. The last portion of or form of radiation is radioactive nuclides or systemic radiation, where we give an unsealed source, where a radiopharmaceutical can be administered intravenously or locally to a target region. A commonly used area of this would be a patient with metastatic prostate cancer. These patients, as the cancer has gone to their bones, results in increased calcium need and repair. So radium-223 can be added to a dichloride, which which the bone mets, the bone areas where they're undergoing repair, can take that up, and next to that chloride, that calcium region, is what's called an alpha particle, which delivers radiation directly to that area. Also, we can link it to various proteins that that can go after certain targets of the cancer themselves. And then lastly, they can even be embedded within resin and injected directly into the tumor. That resin then dissolves and the radiation spills out and gives radiation locally to that area. That's often used in liver tumors. Now, we have spent a lot of time talking a little bit about the radiation forms, how it works, how patients are treated. I wanted to spend a little bit of time helping you understand the possible side effects and how radiation impacts patients. Now, side effects from radiation can happen anywhere we point it. I often tell patients that radiation treatment is a local therapy. So wherever we point it, the organs in that region can potentially have radiation side effects. The way I split that discussion up is there are early effects, which are more common, and then there's late effects, which are rare. Early effects typically happen during the patient's treatment course. They can show up around 1 to 2 weeks once they are undergoing radiation treatment, and this is why I see them weekly. And even after they're done, as the body repairs itself, it can take a couple weeks to resolve. But by the time I see a patient in follow-up around 6 weeks, the acute effects of radiation have kind of resolved. I see the patient, as I described, months to years after to ensure that the patient doesn't have any late effects. Late effects are rare, very rare. When I say rare, I mean less than 1%. But if they occur, they can often be permanent. Now, many times late effects are mild, but in certain situations, they can be quite catastrophic. So there's a lot going on in this slide, but my only purpose of this is to show that each organ, body system, can have both early side effects and also late side effects, and these can all be managed. Oftentimes when a patient is undergoing radiation treatment to the breast, we're managing what I describe as a radiation sunburn, redness, tanning, loss of hair, peeling of the skin. And so by routinely adding ointments, corticosteroids, that can improve, and those kind of resolve after 2 to 3 weeks. Later on in that breast cancer's patient's course, there can be some breast changes, a little bit of hyperpigmentation or tanning. There can sometimes be a little bit of scarring, things like that. Now, other big late effects from radiation, of course, just as chemotherapy can affect fertility, radiation to reproductive organs can also impact fertility of a patient. So oftentimes, if a patient is in family planning, we'll have them go through fertility preservation. Additionally, there can be if a patient is still menstruating, there can be ovarian failure and hormonal changes. In the pediatric population, which I talked about with the use of proton therapy, there can be growth delays from radiation. Cardiotoxicity, which is a relation to effects from radiation to the heart, is something that's studied heavily. Often patients with breast cancer, lymphoma, pediatrics, we have to do everything to kind of avoid the heart. And then lastly, the biggest concern with radiation is something called secondary malignancies. And when I say that, the biggest concern, I mean, when patients discuss radiation with us about their apprehension, when you see it in the news, they're often referring to secondary malignancies. And what that means is cancers caused by radiation. Now, when you start looking at it, it's actually very rare. These cancers often appear 10 to 15 years after the radiation has been given or the radiation exposure. And it's extremely rare. What I mean by that is modern estimates can sometimes be as low as 1 in 25,000. So when I talk about this conversation or counsel patients on secondary malignancies, I often tell them that the benefits of radiation, such as curing their cancer, preventing recurrence, far outweighs this small risk of secondary malignancies. But at the same time, all of our work towards modernizing radiation has been to limit dose. So oftentimes when we counsel pediatric patients, teen patients, radiation, we try to avoid use. We try to limit the dose. We try to limit the techniques. We ensure, for example, proton therapy where there isn't an excess amount of surrounding tissue getting radiation. So in summary, therapeutic radiation plays an integral role in cancer care. Up to 2/3 of cancer patients in the country will require radiation at some point. Radiation impacts tumor cells primarily through the double-strand break in tumor DNA, which results in tumor kill. We reviewed several techniques of radiation therapy: external beam radiation, which is external radiation, brachytherapy, where a radiation source is introduced into a patient, and radiopharmaceuticals, where a patient is injected with kind of a free form of radiation. We briefly reviewed the side effects from radiation, both the early or acute and then the late effects of radiation. Lastly, we are the techniques and radiation forms that I described are offered here at North Kansas City Hospital in our department here at the 2750 building. So, I encourage anyone to come ask questions. We're always available. And so that will conclude my talk, and I appreciate the time. Thank you.